Good afternoon, everybody. I am Grace Pennap from the Microbiology Unit of Nasarawa State University, Kefi, Nigeria. I'm presenting part of the public health services that we render to the community around the university. And what I'm presenting this afternoon is parallel and overlapping prevalence of hepatitis B and C viruses in apparently healthy individuals in a northern Nigerian population. It's very important to actually look at the word apparently healthy. It's different from maybe looking at a particular cohort that is defined, maybe looking at those that are HIV infected or those that have a particular ailment. These are people that are apparently healthy. You wake up and you're feeling good and you think you don't have a problem. And this is simply because the two viruses we're looking at have been referred to by various authors as silent killers. You are infected by these viruses and you don't really know you're infected because they don't have any particular symptoms that makes you believe you're not feeling fine. And we know that these two viruses account for a substantial portion of liver diseases worldwide. And both are endemic in Africa with in fact, the highest prevalence for HCV is in Africa. Egypt is usually quoted for that. Shaleku et al. Did mention in their work that in Nigeria you have about 35 million people living with either of the viruses or a co-infection. And as it is, the infected people remain asymptomatic for a very long time. Transmission of these two viruses usually overlaps, and being endemic in the country, it simply means you can always have them crossing over. Chronic HBV and HCV infections are defined by the detection of the hepatitis B surface antigen and C antibodies respectively. Good progress on antiviral therapy has actually been made. But then, as these infections are largely asymptomatic, patients who might benefit from treatment remain undetected. It is therefore very important to detect such carriers so as to reduce the burden of illness and healthcare costs, to reduce transmission through the reduction of the infected pool, and also to vaccinate contacts of identified carriers. Now, in Africa, we have numerous ailments that actually require blood transfusion. And looking at the endemicity of these two viruses simply means we have a depletion in the number of donors. Also, we have this scourge of the human immunodeficiency virus, and with these two viruses lurking around the corner, we know that they can actually hamper the gains of ART. It is therefore important to suspend these gains of ART and equally have a readily available number of blood donors. This study was therefore mooted to determine the prevalence of these two viruses among apparently healthy people, and also to determine the risk factors affected with the infection, hoping that the findings will contribute to information required to make clinical decisions and also set proactive policies. Materials and methods, it was a cross-sectional study, normal health talk, and then get the informed consent. Ethical clearance was provided by the nearest medical center around after going through the protocol, and then questionnaires were developed, samples collected, and screened. At this juncture, I wish to state that it was not very easy collecting samples from people that, were apparently healthy. Since it wasn't a kind of hospital-based study, it was a bit difficult trying to convince people during the health talk, So it took, rather than maybe having to get so many people in one day, it took some kind of public relation, if I might say, to get up to about 200 people for this study. There were about 48% males and 52 females. The general prevalence was 15%. That's the two viruses combined, HBV and HCV. HBV was 11.5%, and HCV was 3%. And then there was 0.5% co-infection. Some earlier reports of HBV in Nigeria, in pregnant women, reported 16.5, the general population 13.2, HIV population 7.9. HCV has also been reported as 2.3% among the HIV population, 4.5 among a general population, and then 0.8 among pregnant women. Well, these differences in prevalence might be because of the type of the population studied. These are defined populations, so the differences might be because of that, and it could equally be because of the geographic regions that were looked at, and then the cultural practices of the various communities, because the same researchers had actually looked at another community in northern Nigeria that had, it's a published report, that had 13.2% for both HBV and HCV. So sometimes the cultural practices or even methods of viral detection. And one of the problems we've always had is the issue of occult infection. So invariably, our HBV prevalence, I would like to say, is usually underreported because we don't have facilities for now to detect occult hepatitis B virus infection. So all that we can detect is the surface antigen. Now, looking at the details of these results based on age, in all epidemiological studies, we know how important age is. Looking at these results, just the pictorial view, you can see that from the age 16 to 45, it's the highest, it's kind of the peak for everything. And that's not too good for us, because if you're looking at people that are to donate blood, those are the same people that you'll be looking for. And if you're talking about transmission, that's the same group also, because that's the group that is sexually active. So we also have that problem. And you can see that in red actually signifies the HCV, while brown is for the HBV, and the purple is co-infection. Looking at gender, more of the of the females had the HCV infection, whereas HBV was more in the males. Well, there was no statistically significant association, but there were arithmetic differences. And just like I said in my epidemiological presentation yesterday, the issue of statistical association is not sacrosanct when you are dealing with medical issues. Looking at the marital status of these people, we realized that those of the participants that were single had a higher prevalence of HCV than the married, whereas for HBV, those that were married had a higher prevalence. And looking at the history of blood transfusion, HCV seemed to have a higher prevalence of a higher prevalence among those that had not even had a blood transfusion, whereas the reverse occurred in the cases for HBV. A co-infection was only reported among those that had never had a blood transfusion. In all these, the differences were not statistically significant. We also looked at the educational background of the participants, and those we referred to as uneducated were actually a lump of those that I would rather say did not have a formal education, fell in that group. Anybody without a formal education was referred to as uneducated. And we discovered that the educational background showed that the prevalence was higher among those that were uneducated, even though the difference was not statistically significant. But then if you look at the hepatitis B, it was more common among those that even had a primary education, and co-infection was reported only in those with a tertiary education and primary, and also those that were uneducated, although it was higher among those that were uneducated. About more than 5% of them had a core infection. And we looked at occupation of these people. And surprisingly, farmers had a higher prevalence of most of these viruses. And they were also the ones that had a core infection. There was no clear reason for this, but then it's possible that farmers there were more farmers than any other occupational group. So maybe proportionately, that came up. And we looked at facial marks because this study was in an area where you discover that they still have facial marks for identification. In Nigeria, there are certain tribes that have still maintained the culture of having facial marks. It's some kind of scarification on the face. And when we looked at that, we discovered that those that had scarification even had less of both of the viruses than those that did not have. Although, again, the difference was not statistically significant. In conclusion, this study reported an infection of 11.5% with the hepatitis viruses, where 3% was for HCV and HBV in apparently healthy participants. The study also confirms the endemicity of these viruses in the study area, and this high prevalence in apparently healthy people is actually a cause for alarm, because like I had pointed out earlier on, the bulk of people that you look for when you're looking for blood, it's not the young people, the very young people, nor the very elderly people, but the tip, the 18 to 45-year-olds. And this was where we equally saw the high peak of both viruses. Also, there was no, I'm not too sure if I'm comfortable with saying no identifiable risk factors. This is maybe what I should have added was no identifiable risk factors based on statistical association. But with regards to arithmetic differences, of course, we had what we can refer to as identifiable risk factors. But then, looking at the identifiable risk factors vis-a-vis statistical association has now led us to think that it's very possible that there are some obscured factors, that we have not looked at, or is vis-a-vis the transmission of these viruses, or also some locality-specific factors. Because if you look at most of the publications of the Western world, you discover that they have these injection drug users. They are real identifiable means of transmission. But this is a situation that is not very common with us, except where you are looking at maybe institutionalized population. Like maybe if you're talking about the prisons, you're likely to have such things. But by the time you're looking at a village population, you discover that's not a very common thing. So we are thinking that what we need to do is to expand the risk factors that we need to look at vis-a-vis the culture of each of the environment that we are studying. And in our recommendations, these findings actually underscore the importance of screening apparently healthy people for these viruses. And screening should be made available and affordable. There are times that we have things available, but they are not affordable. But we are recommending that it should be affordable so that you can just walk in and know your status at any time. And then to evaluate salient social and cultural practices that may facilitate transmission, and also institute proactive strategies for prevention and control, especially in the case of HCV, where we do not yet have a vaccine. For HBV, fine, but not HCV. Now, future work, we're thinking of looking at larger studies. We're equally thinking of longitudinal studies, and then inclusion of more probable risk factors vis-a-vis sociocultural practices of the study area. We're also thinking of looking at the molecular aspect of these viruses, just to know these, the types that actually circulate in our environment. Like, especially we know about the HCV, the treatment is type specific, the duration of the treatment. So it will be good to know the different genotypes that are circulating in our environment. We wish to acknowledge sincerely all the study participants, staff of Innovative Biotechnology Laboratory for the technical support, and Dr. Nyabam for statistical analysis. Screening asymptomatic persons is an important instrument in disease detection, especially in silent killers like HBV and HCV infections. Thank you.